So an interlaminar endoscopic discectomy is typically performed at L5-S1 for posterior disc herniation. At L5-S1, the interlaminar window is larger, so there's more room to place the tubular retractor through the interlaminar window. That allows us to remove the offending disc herniation without cutting into the joint or destabilizing the spine. Even though we typically perform interlaminar discectomies at L5-S1, sometimes we'll perform it at higher levels if the interlaminar window is wide enough or the pathology calls for it. So the indications for interlaminar endoscopic discectomy are typically posterolateral disc herniations at L5-S1 and sometimes L4-5, as long as the interlaminar window allows room for placement of the endoscope. So the risks of endoscopic spine surgery are very similar to the risks of open spine surgery, and they include terrible things like death, paralysis, infection, bleeding, pain, need for future surgery, risks of anesthesia, risks of spinal fluid leak. The good part is that those risks are minimized with the endoscopic approach because there's less collateral damage to the soft tissues, so those risks are smaller. So with any discectomy, however it's performed, there's a risk of reherniation somewhere between 5 to 10%. And the advantage of having it done endoscopically is the reherniation can be reaccessed through a very small portal once again and still be less invasive than having the traditional discectomy done the first time. We minimize the risks of instability by not having to cut bone or violate the joint. And typically, we can access the spinal canal through a 3 to 4 millimeter incision in the ligamentum flavum, which is the ligament that runs between the bones in the interlaminar window. And since that ligament is rubbery and stretchy, we're actually able to stretch that out to the 7 or 8 millimeter cannula access that we need. The main benefit for interlaminar endoscopic discectomy is we don't remove all the muscle off the back of the spine, we don't drill the bone in the lamina, and we don't violate the joint. When you cut into the joint, you destabilize the spine, and it's more likely to result in instability and need a fusion in the future. Recovery time is very short. Typically, patients are back to driving 2 days after surgery because they don't need to take narcotic medications. And if they can walk on their tiptoes the second day after surgery, they can return to driving. They're allowed to lift up to a gallon of milk, which is about 10 pounds. And we will typically restrict them from returning to heavy bending, lifting, and twisting for approximately 2 weeks.